ESEM 2017. My name is Dr. Stephanie Caden, and I'm the Vice Chair of Emergency Medicine and Chief of International Emergency Medicine at Brigham and Women's Hospital at Harvard University. I'll be moderating the first session today, and I'm very pleased to tell you that we have two wonderful speakers, two colleagues, Dr. Lee Wallace and Dr. Terry Mulligan. They'll each speak for half an hour, and we'll take questions after both have spoken. So let's get right to it. The first speaker will be Dr. Lee Wallace, who will be speaking on the International Federation of Emergency Medicine and the World Health Organization Collaboration, Shaping the Global EM Strategy. Dr. Wallace is president of the International Federation of Emergency Medicine and professor and head of emergency medicine at both the University of Cape Town and Stellenbosch University in South Africa. Dr. Wallace.
Good morning, everybody. It's a great honor to be back in Dubai once again. It's hard to believe that the society is only 5 years old. I feel like I've been coming to Saleh's conferences for many more years than that. Great things that have been happening and will continue to happen. It's very exciting times for emergency medicine in Dubai. I want to tell you about what we're doing within the International Federation. So I have no conflicts of interest. I do some work for WHO, but it's all unpaid. And I'm president of IFEM, and it's all unpaid. So here we are in Dubai, beautiful city, great, the best of everything in the world as far as I can work out. I'm looking forward to going to the Mall of Dubai tomorrow to pay way more than I should do for the things I could buy at home for cheaper. And you have a very well-developed EMS system. I was just talking briefly with Saleh earlier about how far things have come in the last 5 or 10 years. And I understand if you work here, you still see gaps and challenges you want to move forward, but from the outside, very, very impressive system. Response cars that can go at 180 miles an hour will help you meet that 4-minute response time that you're chasing down. And when you get to the emergency department, state-of-the-art in many locations, well-qualified staff, practicing as teams, getting used to simulation and patient volumes and supervision and academic rigor, and it's all planned and rehearsed, hopefully, and executed well. The problem is that most of the world don't live like that. Right? That's something that you will find in the UK, in most of the UK. You find it in much of America, much of Canada, much of Australia, and then isolated pockets in the rest of the world. And the majority of the world's population do not live like that. In fact, the majority of the world's population either live in cities, in low and middle income settings, where they have poor access to emergency health care, or they live in rural areas. About 60% of Africans currently live in rural areas, and that is transitioning. They're moving into cities, and as they move into cities, there are not the houses there to support them, and this is the same in Southeast Asia. So informal housing, overcrowding, and all of the problems that come with that. And from an emergency medicine perspective, thank you, Dr. Srinath, for sharing these couple of pictures with me from India. If this is your call center for your EMS system, you're not going to be meeting a 4-minute response time. And if this is your full staffing for your EMS system, this is Kampala, the newly formed Uganda National Ambulance Service. That is it. You're not going to be meeting anything close to anything like a high-income standard. And the conversations that were being had in the EMS session this morning about quality markers and time markers and KPIs mean nothing in this setting. Many parts of the world, this is the ambulance that you're going to get if you get anything at all, bicycle ambulance. And in many parts of the world, if it's a motorized ambulance, it looks like that. When you get to the emergency department, almost inevitably it is a corner of the hospital that has been allocated as a casualty unit with no thought for design, no thought for privacy, no thought for dignity, infection control, almost no equipment. And I have, obviously, with my background, a lot of pictures from Africa, but it's the same all over the world. Minimal equipment, minimal resources, poorly trained staff, resus rooms that look like this, resus trolleys that look like this. And even in this part of the world where there's incredible wealth and incredible development of systems, actually most of your neighbors right next door to you are like this. And this obviously is an extreme example where hospitals are attacked, but this is an increasingly common problem. And in fact, WHO, it's a United Nations body, so they rarely speak out on anything. Very quick search this morning found all of these just from 2016 where they condemned attacks on hospitals in this region. So we have two very different perspectives. You have the UAE perspective of a very well invested in system that's catching up, I understand, but is investing in people, investing in equipment, investing in systems. And then you have most of the rest of the world where people really are struggling to access healthcare as a basic human right. And when they do access care, they do it when they're acutely ill or injured. And they do that through emergency care, but the system really isn't in place. And I use this quote. Any of you have seen me speak any time in the last 10 years, will you see that I've used this quote in, I think, every talk I give. Even if it's a clinical talk, I manage to drag this in. It's just to say, the message I repeatedly say, that it doesn't matter whether the government of Pakistan, the government of Syria, or the government of Saudi Arabia plan an emergency care system. Patients have emergencies every single day, regardless. The onus is on you in the room to make sure the system is in place to care for them. And there's some global drives to put emergency care in place. There's some World Health Assembly resolutions. We're currently coming to the end of the United Nations Decade of Action on Road Safety. There's only a couple of years left, by which we're supposed to reduce deaths from road injury by 50%. And it's a 5-pillar system, and pillar 5 is post-crash response. There's some legal components to that, like the Good Samaritan law. Excellent to hear that that's almost in place in this part of the world, which is great. Most countries don't have one. But the other part of post-crash response, obviously, is clinical care, and that's emergency care. And then there's the Sustainable Development Goals, 17 goals with 150 targets behind them that all governments have signed up to. And then, of course, there's the burden of disease. So the focus, I always make the point, the focus is always on HIV, TB, and malaria in low and middle-income countries. But actually, injury kills about 60% more people each year than those diseases combined, and a quarter of those are from road crashes. So the target for the United Nations is to save 625,000 lives a year from road injury, road crash deaths, and that is to be done by 2020. Sorry, it's not the best slide, just showing that actually simple interventions in emergency care, like not letting babies die when they're born, actually helping them breathe, drying them, stimulating them, helping them breathe, saves massive numbers of lives, saves massive numbers of disability-adjusted life years, saves massive numbers of years of life lost. In fact, if you look across the spectrum of communicable diseases, non-communicable disease, and injury, emergency care can impact of all the deaths in low middle-income countries each year, all the deaths from every cause, emergency care can impact over half of them, 54%. So a properly functioning emergency care system, in theory, can save over half of all deaths each year in low middle-income settings. When you look back to this region, using a broader use of the word emergency, like displacement of people, natural disasters, and so on. Across the world, 51% of all people who are displaced by emergencies are outside of the EMRO region, the Eastern Mediterranean region for WHO, and 49% are here on your doorstep. Places like Syria, Afghanistan, Iraq, Sudan, Lebanon, Somalia, on your doorstep. They're all EMRO countries, and they carry half of the world's burden of people affected as a result of emergencies and needing health services. And that health service, there's a large element of public health. The clinical care component is emergency care. just again in your very own backyard, here are countries with different grades of the United Nations grades, ongoing emergencies. Grade 3 is the most serious. That's a pretty depressing list of 9 countries in this region, that out of only 21 in the EMRA region, nearly half of them in ongoing emergencies. Okay, so what do we do about it? So from IFEM's point of view and the work with WHO, 3 underpinning principles that I keep espousing, and I understand if you work in private healthcare that there's some issues around the third one about being free at the point of consumption. The point is that no one should be denied emergency care because they cannot pay at the time they need it. I understand there's a whole back-end administration thing to extract the money from them later. I'm being very simplistic and not concerning myself with that. Someone needs emergency care, they get emergency care without extracting money from their wallet before they provide it. I have studied in too many hospitals and watched people dying while their family go and buy drugs at the pharmacy across the road, and they go and buy fluids and an IV set and come back with them and find that the asthma or the status epilepticus has killed the patient. Okay, so the International Federation, it's 26 years old now. It started as a organization really to foster networking and collaboration, and it did a very good job of that for about 20 years of its life. The reality was clear from 5 or 6 years ago that the organization needed to change. All of the new members were from areas of the world that don't have well-developed emergency medicine systems. They don't have well-developed specialties and hundreds of specialists. They are places that live in emergency care parts of the world, not emergency medicine parts of the world. And so, like an oil tanker, we slowly tried to change the direction of IFEM, and I'm very proud to say that we've achieved significant movement with that, to the point that its vision and mission has drastically changed as of this year, and we've made the specialty of emergency medicine still one of our core tenets, driving the specialty of emergency medicine, specialists in emergency medicine and the role that they play in the healthcare system. But more importantly than that is to promote emergency care. Because the reality is and will always be that the overwhelming majority of emergency care will not be provided by specialist physicians. We have a very important role in the system. If you're in high-income countries, certain places, emergency physicians will provide all the patient care, and that's great. The rest of the world, over 90% of patients will have non-specialist physicians providing their emergency care. Emergency physicians leading strategy and policy and education in the country, but not providing frontline care for every patient. And even in those places like Canada, like Australia, where emergency medicine is very robust, still paramedics provide emergency care, nurses provide emergency care, allied health professionals provide emergency care, bystanders provide emergency care. The majority of emergency care is not provided by emergency physicians. And that's really important that everyone understands, because we see the sphere of what we do as emergency doctors and think that that's the boundary of emergency care. It is not. It's way beyond that. And that's where IFEM's trying to focus. And that has been in response to a change in the need and the realization of a bigger picture out there. And it's also in response to, from 2015, WHO Geneva head office appointing their first person to lead emergency care development across the world. Now, obviously, they focus on lower resource settings, but as with any United Nations organization, what they come out with is applicable across the whole world. It's just that many countries will already achieve a higher standard. So the first thing that came out was a definition of the emergency care system, because unless you know what the system is, you can't put a system in place. So what is emergency care? Where does it start? Where does it end? What are the components of it? Well, it's the pre-hospital component, calling an ambulance, having ambulance transport and care, and having some hospital-based care, but it's also providing care at mass gatherings, and also providing care in mass casualty or disaster situations, whether they are man-made or natural. And it's also providing outbreak response and surveillance and all of the emergency public health components. So it's a big system, and it all comes for free. All of these other parts of it come for free when you put the basic emergency care system in place. I know in Dubai, if you're buying Lamborghinis as ambulances, this probably isn't that relevant to you. But if you're in Syria or Sudan or many of the other countries right on the doorstep here, this is one of the most important messages to take away. I keep getting challenged by policymakers in African countries. We can't afford emergency care. Mercedes ambulances are very expensive. Well, sorry, I don't know what's happened to my formatting there. If you staff a formal ambulance service in a rural area, it's $284 a year life gained. So for each year of life gained, $284 to have a system in place. In a city, it's about a third of that, $94. But if you use volunteers, trained volunteers and paramedics, it's $7 per year of life gain. Just to give you a sense, when I first saw these numbers, I had no idea if that's good value or bad value. We invest billions in HIV care every year, literally billions, tens of billions of dollars, because it's very cost effective to keep someone alive on antiretroviral therapy for $922 per year of life gained. $7, $922. No one ever questions that we should be providing highly active antiretroviral therapy. But people question every single day, do we really need an ambulance system? Can we really afford a pre-hospital care system? Even hospital-based emergency care, depending on where you look and how you measure it, it's some distinction. But again, if you look at the cost per year of life gained, it's cheap. It's as low as $78, whereas for comparison, $8,000 for a year of life gained from renal dialysis and TB treatment over $1,000. What we do is cheap. Cheap things, simple things save lives, and they help us meet the Sustainable Development Goal targets, like reducing maternal death rates, like reducing neonatal and under 5 death rates, like reducing motor vehicle collision death rates, like reducing death from violence overall. We can drive 10 Sustainable Development Goal targets just through the emergency care system. Okay, so just some detail on what IFEM have been helping WHO to do. These are all WHO initiatives, clearly. I don't speak on behalf of WHO, but IFEM is at the table. Whenever anything happens at WHO in emergency care, we are at the top table. We are co-hosts and co-conveners. So the system is 3 parts. It's scene, transfer, and facility. This is intuitive to all of you, I guess, but there was a question downstairs earlier about should there be standards for paramedic training and curricula across the world? Well, yes, probably, maybe. But now with this system definition, we can actually start to answer questions like that. What should care be in the back of an ambulance as an absolute minimum? So you can break it down by the scene and by transfer and by facility, and so it turns out that actually transfer is 2 parts. So you need two people. You need a driver and you need someone to provide care. There are many parts of the world where bicycle ambulances are used, which is great. It gets someone to the clinic, but it's actually not an ambulance because you can't provide care while you are cycling the ambulance. So at the scene, it's bystander response, dispatch and provider response, and there's some simple components to that. Transfer, in answer to the question about the curriculum, is really just transport and transport care, and you can define transport care, and we've done that to include simple ABC stabilization, avoidance of further injury, protection of the airway, and that drives what minimum equipment you need as well. So that's all now in place, and facility, I'm sure most of you are facility-based and know this way better than I do, what happens when you arrive in a facility. But just note that emergency care does include early inpatient surgery and critical care as well. It's not clear where that finishes, where the back door of that is, but some component of inpatient care is emergency care. Okay, so once you know what the system is, you can start to interrogate, how is my system doing? Where do I need to develop? How do I develop people, so training? And how do I measure and continue to improve things? So there's a whole bunch of products. The ones with the dashed lines on them are still in draft, but I want to just show you some of the more exciting things that have come out. Some are out and are being used widely, and some are in the final stages of piloting and will be out very soon. So the Emergency Care System Assessment Tool, I saw Junaid Razak here from Pakistan. This has just happened in Pakistan very recently. Actually, WHO EMRO region, your region, is driving this very hard. They want all EMRO countries to have this assessment done in the next year or two. It's been driven very hard centrally. So this is a national assessment of how well your system functions against the system framework. So one of the measures in here that's actually a really interesting measure in terms of quality of your ambulance services, what percentage of the population can access an ambulance within X amount of time? And what percentage of the population can access the free-to-use universal access number all the time? And actually, when you look at that, even this has been done in countries as diverse as Scotland and Ghana, and the whole range in between. And every question is scored. 5 is a maximum and 1 is the minimum. And not every country, even when you think you've got a robust system, not every country scores 5 on everything by any means. And it gives you a roadmap to develop. So it's a 50 to 100 people complete the survey. You have a 2-day meeting to debate the findings, and you come out with a 5-year strategic roadmap to develop emergency care system in your country. And this has been done now in about 30 countries. It's a really exciting process. We've done it at home in South Africa, and we have now annual meetings where the National Department of Health and the Minister hold us accountable for progress against this set of priorities. There's now a facility assessment tool. WHO have chosen the term emergency unit, but there's a facility assessment tool so that instead of just looking at your whole system, you can now go to your facility and say, do we meet the minimum requirements? Where do we need to improve? What equipment do we need? What skills do we need? What infrastructure do we need in place? Moving from assessment to actually care delivery, the trauma care checklist is a 1-page, it's just a piece of paper. You can print as many copies as you want. It's open access. It's a 1-page checklist that helps drive your emergency care of the trauma patient. So it asks questions like, have you considered hemopneumothorax? And you can tick yes. Chest drain placed, or you can tick no, and then it drives you to actually consider that. It's like taking you through the ATLS steps. This was introduced in a number of countries and studied by Charlie Mock and his team and produced a 50% mortality reduction. No other change in care, only the introduction of a trauma care checklist. It's the only thing they did. They introduced a piece of paper. Every patient had that checklist filled on them and saved 50% of previous deaths. This is something that I'm particularly excited about. I have a personal interest in triage. We've brought out 3 triage tools, 1 for mass casualty use. This is final and is ready to use now, today, if anyone wants to use it. There's a pre-hospital tool which is ready for piloting, for day-to-day use and for surge use. And then there's a hospital-based tool, which is still at the draft. You see it says draft on it. It's still at the draft stage. We are looking for countries to pilot this, to give us particularly some feedback on the discriminators and the physiology used in it. But it's a 3 or 4 color triage system. So if your system's more advanced, you can introduce an orange color. It's based from the South African triage scale through a consensus process. And actually in South Africa, we're going to flip, I haven't told them yet, but we're going to flip from the South African triage scale and use the WHO tool once the piloting's done. And so there's one for over 12 and over, and there's one for under 12, and there's definitions that go with it. What's a high-risk trauma, and what's a threatened limb, and so on. So a trauma care checklist to save lives, a triage tool. You all know the value of triage, right? I don't need to tell anyone in this room the value of triage, but most emergency receiving areas in the world do not triage patients today, hence the need for a tool. This is particularly exciting. I rail quite often against ATLS and ACLS, and I think they have a great place in Dubai. They have very little place in rural Uganda. And yet you'll find them being taught there. So frontline providers who see emergencies on a daily basis but who don't have any training, there's now a WHO course to teach basic emergency care to healthcare professionals, doctors, nurses, medics, doesn't matter who. It needs a healthcare qualification but doesn't need emergency care knowledge going into it. And you'll see it's a joint product, and the Triage tool and a number of other tools are going to come out like this. They will be WHO, International Committee of Red Cross, and IFEM. Some of them maybe with Médecins Sans Frontières as well. But that is the front cover of the BEC book that is now in print, and there's the IFEM logo on it. We're very proud of that we are an equal partner in this product, and it's been used in many countries. We're rolling it out in several African countries. At the moment, it's been used in, we've just trained 250 people across 10 districts in Uganda last month, which now makes about 1,000 we've trained there. We're doing a similar thing in Zambia and so on. Coming down the line very soon is a minimum data set for emergency care. So if you have a registry in place, we just received a very significant grant this week to pilot this and to refine it. But if you have a WHO registry in place or your own registry, there's a minimum data set list to make sure that countries can compare against each other. At the moment, everyone's got their own trauma registry and everyone's got their own emergency registry, and they all collect different data. So the minimum data set will help to facilitate inter-country and regional comparisons. Then there's this essential resources for emergency care, a resource list and a bundled, palleted, ready to dispatch on the back of a plane kit list of a minimum set of equipment and drugs that should be in every emergency unit, whether it's in a hospital that's been bombed in Syria or whether it's in your hospital here in the private sector in Dubai. This is the absolute minimum that you need to function as an emergency unit. That is coming very soon. And then we are in a process now which I really wish I wasn't in. I really don't like this, but we are thrashing our way through a lot of, we've just done a systematic review and identified over 6,000 quality indicators for emergency care, and we're trying to agree 5 out of that. So that is also coming, and then you'll be able to measure your system. I understand everyone's got their own way of measuring their system, and some more robust than others. The problem is you can't compare across countries and in regions. So particularly in the EMR region, this part of the world, it's going to be really important when you have countries like Syria and Afghanistan and countries like the UAE and everything in between. Standardization is going to be very important for countries to lift themselves up. Just one last thing, which is coming to a conclusion early in 2018. There's a Lancet commission that we're just finishing off now on non-communicable disease and injury in the poorest population. We started with the poorest billion, and it's not clear if that's exactly what we mean, but the poorest people on the planet actually have different diseases to wealthy people, and we say, so NCDs are caused by salt and alcohol and smoking. No, they're not in the poorest people. They're caused by other things like infections. So how do you apply emergency care in that population? Should it look different to how it looks in other countries? So please keep your eye out for that. And as of about 2 hours ago, we've got 2 papers now in the Lancet coming up, one defining what emergency care is and one defining how much it costs to provide emergency care. So I hope they will help you in your efforts to keep improving care in the region. Thank you very much.
Thank you, Dr. Wallis.